Hey, Med class. I have Dr. Sara Cheng here to talk to you about what she does. Thank you so much for joining us today. And a much more obscure way of doing this med class. Next year, we hope to be back in normal session.
Thanks, Mr. Stirrup. Hi, Cherry Creek High School. Thanks for having me back. I did this a couple years ago and really enjoyed it. And although it'd be better to see you in person, I'm really glad to be here. So my name's Sara Cheng. I have an MD and a PhD from the University of Michigan, and I'm a practicing anesthesiologist in Denver, Colorado. So I'm going to tell you a little bit about what I do and then offer some kind of random, kind of slightly philosophical questions to get you thinking about what you might want to do if you choose to practice in the medical field, and hope to establish some connections with you. If you guys ever want to talk about anything, I will leave all my information with Mr. Stirrup. So a little bit about me. Let's see if I can get my technology working here. So I was a biology major at Stanford University. I got a dual graduate degree at the University of Michigan, and then I did an anesthesia residency at the University of Colorado. After my residency, I did an additional year of fellowship where I specialized in anesthesia for transplant, specifically liver and kidney. And then now I am a private practice anesthesiologist in Denver. So I wanted to address some of the myths about anesthesia. I think that at least one anesthesiologist has gone before me in this talk series. And so they've told you maybe a little bit about what we do. And so I'm going to just come at it from a slightly different perspective and address some of the myths. So myths about anesthesia that you might have, whether it's from lack of education or from the stereotypes that you see on TV and the movies, some myths that might come up. We choose anesthesia so that we don't have to talk to people. That's number one. Number two, we have an easy job. We just turn the gas on and turn it off and we're out of there. So it's an easy job. That's another myth. And the third myth is that we are pretty hands-off, that we don't do procedures, that we don't kind of get involved with the patient. And that's Dr. Woodward. Okay, I'll silence her. So let's go through these myths a little bit. Myth number one, we don't like talking to people. So there's this belief that, you kind of go into anesthesia if you just are really uncomfortable around awake patients. And I would have to say that just couldn't be farther from the truth. I'll tell you what a typical day is like for me. I call my patients the night before surgery. I arrive at the hospital at 6:30 in the morning for a first case start at 7:30. I change my clothes, I go evaluate the first patient in pre-op and decide on an anesthetic plan. Then I go prepare my operating room for anesthesia. That means I drop all my drugs, set up the room with all the equipment and other tools necessary to do the anesthetic. And I might do that anywhere from 1 to 10 times that day. Go out and meet a new patient, establish rapport, do a history and physical, go back and work with the team, and then do it all over again. So if I was really did not enjoy interacting with people, or if those kind of new interactions, meeting a new patient, were a constant source of stress to me, then this would be a terrible job for me. So people skills are essential. And they're also essential because surgery is a team sport. Okay, we never work in isolation. We always work in teams. This is the neuroendocrine surgery team. I'm in front there because I'm the shortest. But there's the surgeon, there's the surgical assistant, the physician assistant, the scrub nurse, and the scrub tech, and circulator nurse. So there are a whole bunch of people there, and we always work together as a team. So again, if you like working in isolation, if you like being in a little box and looking at your computer, then being part of the operating team is not for you. Just to expand that a little bit, what's a typical month for me like? It involves interacting with a lot of people. I'm probably on call overnight for emergencies once a week. I work weekends about once a month, and my case mix is really diverse. I work with people all over the hospital and all over the city, doing abdominal procedures for cancer, helping laboring women in the obstetrics suite with their labor pain, sedations for colonoscopy, lung surgery, brain surgery, knee replacements, transplants. We work with so many different teams all over the hospital. And again, there's a lot of teamwork involved. And I just thought this would be fun to show you if it works for me. Yep, here's me dancing. Here's me doing a boomerang. Look how cool I am. Doing a boomerang with Dr. Eric Liu. He's our neuroendocrine surgeon at Pres St. Luke's. I work with him a lot. I actually head his anesthesia team. Here's another one, just for fun. Me dancing with Dr. Barilot. Dr. Barilot is a neurosurgeon who implants different devices for pain. He puts spinal cord stimulators and peripheral nerve stimulators in for pain to help people with chronic pain. And so I like dancing with all my surgeons, and it just shows how much fun we have working together. Let's see, myth number 2. Okay, let's move on. It's super boring. All we do is turn the gas on and off. There's really nothing to it other than that. I would say that that is a oversimplification. Oh, let's see, look at my slide over here. We keep people alive during what would otherwise be a lethal event. If you think about it, all the surgeries that we do, or a lot of them, they would be like, you know, life-threatening procedures for these patients, and obviously agonizing unless we were there. So keeping people alive during this kind of event takes a lot of work. Securing the airway, choosing the medications, monitoring all the drips, monitoring blood pressure, basically doing everything that that patient requires. Every molecule that comes in and out of that patient, we watch. And so there is a lot of skill and know-how that goes into resuscitating somebody during and after what would otherwise be a lethal event. Here's a picture of the top drawer of my drug cart here. I think I'm gonna try to, anyway, not ideal, but here. And you can see that this is just the top of the drug cart. There's about 6 drawers that look like this. And whenever I do a general anesthetic, so the simplest general anesthetic, when I am putting someone to sleep for a simple procedure, I'll use a minimum of 10 medications. And I really need to know the mechanism of action, the indication, the duration, the side effects, the metabolism, and the contraindications for every drug in this drawer and all the other ones at my disposal. So there's a lot of applied pharmacology that goes into the practice of anesthesia, and we are the kind of the high-tech bartenders of the operating room, if you will. Trauma resuscitation is a really specific skill that I take trauma call at Aurora South periodically, and this is the floor of our operating room after a gunshot wound victim. These are all the packs of red blood cells that we gave, and these are probably plasma, and then down here is all the clear liquids, the crystalloid that we gave during that resuscitation. You know, working with the surgical team during a trauma like this is also a very special skill on the part of the anesthesiologist. We also get to do such varied things. I love that about anesthesia, that we get to work all over the hospital. So pediatric anesthesia, working with these little guys in the operating room and putting them to sleep in a non-traumatic and safe fashion is a really special skill. Working in the obstetric suite. So here, the anesthesiologist right over here is placing a spinal, which will make this woman numb from about the xiphoid process down, so that she can then lie down and have a C-section without any pain. And being part of labor and delivery is a really special and unique part of anesthesia practice. Transplant anesthesia, that's my specialty. That's what I did my fellowship in. Here we have a picture of a diseased liver, and what it looks like after it has been transplanted with a healthy donor liver. You can see that we have to make a major cut here and here across the inferior vena cava. We also have to cut across the hepatic artery and portal vein, rather the surgeon does. But taking keeping this patient alive while you're cutting this organ out is no small feat. I actually like to say that it is harder than open heart surgery in a way, because there is a backup machine for the heart and the lungs. But there is no backup machine for the liver. If we can't get that liver back in a timely fashion, that patient will not survive. So liver transplant anesthesia is also a pretty neat specialty within our practice. Let's see. So it's not boring, that's for sure. Myth number 3: we don't do procedures. We, anesthesia is kind of the ultimate place for doing lots of satisfying small procedures. We might not do curative procedures. The surgery, the main surgery is the curative procedure, but all the things we do help facilitate these things in a safe and pain-free manner. So nerve blocks are a core skill in anesthesia. Here we have the anesthesiologist putting an ultrasound probe on the anterior part of the thigh and putting a needle through the skin. And that needle through the skin is aiming for this bright bunch of nerves right here, okay? And that anesthesiologist is going to inject some local anesthetic to numb the activity or quell the activity of that nerve so that all the pain sensations coming up from that knee are blocked. And that's a way to keep somebody comfortable without giving them narcotics. As we all know, minimizing narcotics is a big public health push right now. Neuraxial anesthesia. This refers to different ways to inject numbing medicine around the spinal cord. Here we have a patient's back, and there is a small, tiny catheter coming out of this patient's back. This catheter is so thin, it looks like fishing line. Actually, you can't even tell there's a lumen in there, but there is, and we use it to inject numbing medicine around the spine, and that can help with labor pain. It can also help with pain from an abdominal incision. Airway management. Airway management is a key skill in anesthesiology and one of our main daily procedures. Here you have an anesthesiologist about to place what we call a laryngoscope in this patient's mouth. And the laryngoscope is there to facilitate placement of an endotracheal tube. So here's a side view of the laryngoscope, which is pulling the tongue upwards so that the anesthesiologist's eyes, which are here, can see the top of the breathing tube, which is the trachea, and the top of it is called the larynx or the glottis. So inserting this laryngoscope allows the anesthesiologist to be able to place that breathing tube. Over here on the right is the same side view, but instead of placing a breathing tube, the anesthesiologist is placing what we call a laryngeal mask. It sits right up here on top of the tongue. It does not go down into the trachea. So it ends up sitting right here and kind of cupping the larynx, preventing that tongue from falling back and preventing that patient from snoring while they're asleep, which can obstruct airflow. What else? Invasive lines. So arterial lines and central lines are two different invasive lines that we place often in the operating room. Arterial lines are often placed in the wrist and the radial artery here. Okay, it's also pictured right here. And these allow us to perform real-time measurements of the blood pressure with every beat instead of waiting for that blood pressure cuff to come off. It also allows us to take blood samples. And an invasive line here, this is one kind of invasive line. It's called a central venous line. And it sits in a major vein that's going down to the heart here. It allows us to monitor fluid status and also give medications directly to the heart compartment. So I do a lot of those with the kind of cases that I do. So I'm going to switch gears a little bit. I talked a little bit about those 3 myths of anesthesia and tried to dispel them for you. I think it is actually a really, really amazing specialty. I love my job. So I'm going to switch gears now and just talk a little bit about some thoughts I'd like to share with students who are thinking about getting involved in healthcare and wondering what they want to pursue. Okay, so how to choose a career in healthcare, random thoughts in no particular order. One thing to just ask yourself is, do you need to be the boss? Okay, do you need to run the show? Um, because the different kinds of ways that you can be involved in healthcare involve different amounts of responsibility. Okay, even in, you know, I'm a physician and I may have more responsibility or more uh, be able to give orders more than like a nurse or a respiratory therapist or something, but the surgeon really runs the show in the operating room. And so there are levels of kind of authority there, and, you know, where do you want to be in the hierarchy? Because there is a hierarchy, even though there's also a lot of teamwork. So, you know, being the boss is awesome, right? You get to tell people what to do. You have the final say. It happens the way you want it to. It happens the way you believe it should go. That can be awesome. You know, to be the physician in the room can be awesome. Being the boss can also stink. All right, all of it comes back to you. If anything happens to that patient, it is your responsibility. Okay, it doesn't matter if the nurse made a mistake. It doesn't matter if the intake person made a mistake. It doesn't matter if the patient answered the wrong questions. If you're the physician, you are captain of the ship, and all of it comes back to you. And so running that whole situation and taking responsibility for everything that's happening on the team below you, can be a hard thing to swallow. And being the boss is deceiving. If you're the boss, you might say that, you know, you get to dictate how things go. You get to dictate when you work. You get to dictate when you get to go on vacation. And that is simply not true. When you're in charge of things, you are employing all these people. You have to be sure 24/7 that everything is running the way you want it to. And so being the boss doesn't mean doing what you want all the time. Other questions to ask yourself: do you want or need patient continuity? If the answer is, and that means seeing the same patient more than once, seeing them again and again over a period of time, following them and following up on them. If you want that, if you crave that and you want to be a physician, then specialties like family medicine, internal medicine allow for that or are based on that. And many medical subspecialties too, like allergy, GI, nephrology, they see their patients over and over and really get to know them over time, even over a lifetime. If that is not necessarily something you need, then episodic encounters or specialties that allow those episodic encounters, like emergency medicine and anesthesiology, might be for you. It's funny because I love people. I love having close friendships and close relationships. And I really thought that I needed that continuity from my career as well. And it turned out that I didn't. You know, I'm okay with usually not seeing that patient again. I get that kind of continuity that my personality needs from my relationships outside of the operating room. Let's see. Do you want any patient interaction? If you really want to interact with patients, then family medicine, internal medicine, all these surgical subspecialties, including my own, would be a good fit for you. But if you love the idea of being a physician, of having that mindset, but you don't necessarily need to interact with patients every day, then there are other things like pathology and radiology that are also extremely important and extremely fulfilling. I've always found both of those specialties so fascinating because every single x-ray and every single slide is an answer. It's always an answer, even if the answer is no. So those specialties are so important. What settings do you like? And you know, this is more like if you went to medical school. Well, I guess you could ask yourself even before you go to medical school, but I'm asking all my third-year medical students this now. What settings do you like to practice in? The clinic, the hospital, the emergency room, the OR, or out in the field, battlefield medicine, you know. All these things are really important too. Like surgeons, you might say surgeons love the operating room, and that's true, but they have to run a clinic. they get patients to the OR by seeing them in clinic first and consulting with them and talking to them. So they need to be able to at least stand the clinic, if not like it, in order to spend that time in the OR. Whereas, you know, for myself, I never have to see the clinic again. The operating room is the workplace for me, and that suits me just fine. Do you like procedures? That's another thing. There are plenty of specialties that are very hands-on, surgery being the most obvious one, but interventional cardiologists, interventional radiologists and pulmonologists do a lot of invasive procedures. Myself, I do, as an anesthesiologist, do a lot of small procedures, and obviously obstetricians and gynecologists do a lot of procedures as well. So there are other specialties, though, which do not do a lot of hands-on procedures. So if you're a pediatrician, an internist, a neurologist, a psychiatrist, I mean, you might spend a lot of time talking to patients and thinking about their problems and doing a lot of consultation with your subspecialty colleagues on how to best take care of your patients. But if they need procedures, you would refer those patients out to someone who does those procedures. So having that kind of eye and hand dexterity is very important in the subspecialties that do procedures. And finally, I think, you know, there are a couple of fuzzier ones here too, but what kind of decision maker are you? Do you need all the facts before you decide what to do? Or do you need or just enjoy the time to deliberate about the best course of action? On the other hand, are you that kind of person who, like, after you've kind of gone through the first couple questions, you need to do something about it? You can't sit around and think about it anymore. You have to get going and do something about it. That can also kind of drive you towards one specialty or another. So that's just some stuff to think about, some fuzzy, floofy kind of stuff to think about. You know, early now where you guys are sitting, it's good to just think really broadly. Don't think about what kind of doctor do I want to be. Think broadly about who am I and what am I interested in. So some specifics, if you're thinking after listening to me blab about all this that you're interested in anesthesiology, how do you become an anesthesiologist? Well, you graduate high school, you go to 4 years of college, 4 years of medical school, and 4 years of residency. And the first year of that residency is called internship. As you can see, there's a significant time and monetary investment in becoming a physician of any kind. And so I think, you know, it's a really important question to ask yourself too, like, is these things that I've decided that I like seeing patients, I like seeing them in the clinic, I like continuity of care. Could you do those things without becoming a doctor? I think that's always a good question to ask yourself, because there's a significant investment here, and you need to know in your heart that I wouldn't be happy doing anything else but being a physician, because there will be times when it's hard and it gets long. Now, what do I love about being an anesthesiologist? I mean, I love my job. You can probably tell from my boomerangs that I love my job. And some of the things, what are some of the things that I enjoy about it? I get to be there for people during probably one of the most stressful days in their entire lives. And it is such an honor, and it is such a privilege to both bring, you know, your skills and your kindness to bear in every one of those moments. I really feel so strongly about that. It is both an extremely technical and an extremely emotional job. You know, there are a lot of technical aspects to it that I'm thinking about all the time, and I really only share with the patient if it's going to help them to understand how I'm helping them. But that emotional support as well, and rapport building with them is also very satisfying. I also like, it's a little bit like being a parent in some ways, in that I get to discuss things with my patients. I get to discuss best choices of actions, but in the end, I usually get to do what I think is best. when that patient's asleep, I'm not asking them every 5 minutes, is it okay if I give you this medication, right? When you deal with awake patients, it's different. There is a lot more kind of discussion and give and take, and there absolutely should be. But during anesthesia, there does come a point where I call the shots, and I do enjoy that part of it as well. One very important thing that I love about anesthesia is that I get to finish a task every single day. I get a sense of task completion every day. When I finish that case, I'm done. I have checked off everything that I need to do for that patient, and I can leave the hospital kind of feeling that that task is completed. And I love that feeling. I mean, I think all our primary care specialties are so important. But I would just be so frustrated if I was like working on someone to control their blood pressure, and I gave them a pill to take, and they came back 6 weeks later and they didn't take the pill. I mean, that would be like, what am I doing here? And you know, again, that kind of work is so important, but for me, that I would find that really frustrating. So I love kind of the immediacy of my job and the sense of task completion each day. And finally, the variety. You know, I get to work all over the hospital. I get to work with so many different kinds of patients and surgeons and nurses, and I really do love that. So I'm just going to end with one of my favorite Maya Angelou quotes. She had said, "I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel." And I feel like this is so pertinent to the practice of anesthesia, because my patients, they will never know. They will never know what I actually did to keep them safe. But they will know that I made them feel safe. And so keeping our patients, keeping them actually safe and making them feel safe is the crux of anesthesia. Thanks, guys.